Hello, good afternoon, everyone. Good morning, good evening as well. Welcome, ladies. Hopefully, we'll have some others joining us in a few minutes, and hopefully, we will have gentlemen, guys, gals, and non-binary pals. Most of you know I'm Monique Springer, project officer with UWIHARP, and I'm joined today with Kelia Anderson, our project assistant. A very special welcome to our students, staff members, colleagues with the National HIV/AIDS Commission, off-campus partners, repeat visitors, and to our new guests. UWIHARP is the HIV Sexual Health Unit at UWI, and we seek to positively influence the sexual and reproductive health and wellness of the university population and the wider Caribbean society. Our primary focus is the development of sexual health literacy among the community through programs such as our digital dialogues. These are sexual health conversations, and they will be held during the semester. They include the S-File Sexual Health Discussion Series on a wide range of topics, and the Shock Series, which will focus on sexual health issues among our vulnerable Caribbean populations during COVID-19. So you can look out for our flyers on our social media platforms, Facebook, Instagram, the UWI app, and through student UWI emails. There are few participating guidelines. All mics are muted and videos are turned off. Q&A will take place after the presentation and the mics will be unmuted. We ask you to post your questions or comments during the presentation in the chat pod located at the bottom of the screen. We aim to address as many as possible at the end of the presentation. Alternatively, you can message me directly if you prefer. For those questions we couldn't get to, please email them to uwiharp@kphil.uwi.edu before the end of the day, and we will address them shortly. Afterwards, the sessions will be recorded and the recordings will be posted. Right, so the sessions, as I said, will be recorded and the recordings will be posted afterwards on our social media platforms, including our YouTube channel, which is UWIHARP Cave Hill. And these will be done without sensitive personal discussions to protect participants' confidentiality. However, please know that we cannot guarantee confidentiality in this public forum among participants. So be cautious about what personal information you disclose about yourself and others. It is safer to talk in general terms. Also, please complete the evaluation form that will be sent to you after the discussion. You can suggest topics that you're interested in for us to facilitate. We have a few rules, some of which were adapted from the HIV 2020 online. UWIHARP's digital dialogues provide a safe space to address a range of sexual health topics using a sex-positive approach. We encourage participants to share their knowledge, experiences, and opinions in a respectful manner. You may disagree with views highlighted today. However, please be respectful of other outlooks, regardless of your religious or moral beliefs. Let us be mindful in the way we discuss sensitive topics. UWIHARP operates on a zero-tolerance policy for any kind of abusive, discriminatory, belligerent, or disparaging comments or actions that may cause distress to presenters and/or participants. Persons who engage in any undesirable behaviors will be immediately removed from the webinar unannounced. UWIHARP's guiding principle is to first do no harm. And today we have a very exciting topic. We will be looking at obesity, NCDs, and sexual health, and looking at what are the linkages. And as many of you may know, the Caribbean and Barbados included have very high rates of NCDs. But I find that there's very little consideration or thought given to the linkages with sexual and reproductive health. And in fact, the WHO identifies NCDs as the world's biggest killer. And today we have Dr. Rashida Daisley, and she's the medical director at the Barbados Family Planning Association, also known as BFPA. She is a medical doctor with a burgeoning interest for public health advocacy and policy development. Stemming from her personal and professional experience, Rashida is passionate about the prevention and management of obesity and sexual and reproductive health advocacy. a Damnita and Arabaro Trust Fund awardee. She has recently completed her Masters of International Public Health with merit at the University of Birmingham, a Russell Group University, and a world leader in obesity research. A member of the World Obesity Federation, the UK Association for the Study of Obesity, and 2018 Scope School Brazil attendee, she used her acumen to raise awareness of childhood obesity prevention in Barbados by volunteering with the Healthy Caribbean School Outreach Program and as part of the Barbados Childhood Obesity Prevention Coalition. So I now invite Dr. Daisley to share her slides with us, and she can begin her presentation when she's ready, and then hopefully we will have a very engaging conversation after. I have a few questions and some input as we go along. So Dr. Daisley, I welcome you to the floor.
Good afternoon, everyone. First of all, can everybody see my screen? Just want to make sure. Okay, good. All righty. So thank you so much for having me here today to present on two separate topics that are actually very near and dear to my heart. But as you said, Moni, in the introduction, they're all not often linked together, but there are quite a few overlaps between both obesity and sexual and reproductive health. So as you said, I'm the clinical director of BFPA. Also in my introduction, I do a lot of work and I do have a big passion for obesity prevention and management. I am a part of the UK study for obesity. What you would have mentioned there in terms of Scope School Brazil, the World Obesity Federation had granted me a scholarship to attend a short conference in Brazil about obesity prevention, particularly in third world countries. So that was actually very, very informative. And I am still an active member of the Childhood Obesity Coalition, as well as BFPA. Okay. So a bit of the outline in terms of what we'll be talking about today. Of course, we'll start with obesity. What is obesity? How we define and classify obesity. We're also going to talk about the health consequences. I'm going to just touch a little bit on health consequences outside of sexual and reproductive health before we get into the real meat of the matter. We're also going to touch a little bit on sexual and reproductive health, and then we'll link the two. Okay. So let's start at the beginning. What is obesity? So I have quite a wordy definition here, and this was taken from the American Medical Association. It says obesity is defined as a chronic, relapsing, multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue, which is fat tissue dysfunction, abnormal fat mass physical forces, and it results in adverse metabolic, biochemical, and psychosocial health consequences. Now that's quite a bit of words that we need to take in. So what I did is I just really highlighted the points that we need to pick from this. So chronic, relapsing, multifactorial. I also should have highlighted neurobehavioral as well, but that can also fall into multifactorial. Obviously the increase in body fat and the resulting adverse outcomes related to obesity. So let's dive into what these all mean. So we'll first start with chronic. So chronic, as we all know, means that it requires lifelong management. I think that there's a big misconception out there that once persons lose weight, that's it. They can go about, they never regain the weight, but that is definitely not the case. Obesity, which is now classified as a disease, actually, is something that needs to be is chronic and needs to be managed in a lifelong perspective. So that brings me to relapsing. So often persons might lose weight, but more often than not, you would see persons that they might regain the weight 5 years down the road, 10 years down the road. And that's the nature of obesity management. Sometimes persons are not able to maintain the weight, and that's actually the hardest part of weight loss. Multifactorial. So this is something that I really like to read about. Persons think that obesity development is as simple as the balance between energy intake and energy expenditure, but it's not that simple. There are myriad of different factors that really come into play in the development of obesity. And they're not only at the individual level in terms of what the person eats or their exercise, but we also have to think about the wider landscape, the foodscape, the actual physical landscape. For example, in Barbados, our roads are not really conducive for much walking versus in other countries, you might notice that they have nice sidewalks that persons will be able to walk from home to school very easily. So that's a consideration in terms of the landscape. Disease, as I said before, obesity has now been classified as a disease, and I think that really does justice to the condition. And that means that it really does require physician intervention to make sure that any diets or weight loss strategies are safe and done in a way that can be sustainable. And lastly, the multiplicity of adverse outcomes that can negatively affect your life as a result of obesity. So again, touching here on the causes of obesity. So this is kind of structured in the same way that I was talking just now. Closer to the person in the middle here, you would notice different things related to the person themselves, nutrition, hormones, metabolism, their genetics, stress, which is actually a big factor, exercise. But in the white hexagons, you can see here that similar things that I would have just been speaking about: food and production policy, healthcare policy and delivery. Finances is a really big factor that we'll look a little bit more on the intricacy of how that plays into obesity development. Education and parenting, work and business culture, as well as community and lifestyle. So let's look a little bit more about the trends in obesity. So I have a few graphs here that I felt would help us to really see this a lot better. So this first graph here is able to stratify obesity rates by men and women, also by year, but what the information I really want you to get here is from the different regions. So we can see from first glancing this across all of these areas that obesity prevalence has been gradually increasing from 1980 to 2016. But we can see that women, as ladies would probably know, we definitely do have higher body fat percentage than men and increased incidence of obesity. But you can also look at the high income countries that tend to have a lot more higher prevalence of obesity compared to those with lower socioeconomic status. But interestingly enough, we can look at areas like Central Asia and North Africa that might not necessarily be thought of to be high income, and they're more like low income. And that can speak to the double burden of disease, where these countries not only have to deal with malnutrition in terms of low nutritional status, but now they also have to deal with tackling obesity also with infectious diseases that these countries sometimes grapple with. This trend here I thought was also quite interesting. It stratifies it once again based on socioeconomic status. So we can see here that low income countries, as we would think, have lower prevalence, and most of the groups tend to have a similar upward trend. But we can see that the high income countries, which had the highest prevalence around 1980, as we come further along towards 2016, we can see that they're now having a less steep trend than the upper middle income. And that can really help untangling what's happening there, can really help us to get a bit more information about the etiology. So we would have cast our memory back into that first slide where I was talking about the different aspects, and I said things like education as well as finances. So I'm sure many of us would know that right now, especially with COVID and economic implications, we might not always have the financial luxury to go and pay for gym membership. Some persons are able to get meal prepping and people to come in and cook for them. So these high-income countries, those persons might be able to afford that, versus the upper middle income and lower middle income, they might not be able to really afford that, and that can speak to the higher trend there. So obesity in terms of its implications have a really big burden on economy, sorry. And that's not only at the individual level, but also in terms of the wider healthcare expenditure. And as no surprise, USA tops this list in terms of their expenditure related to obesity with up to 644, I think this is million dollars that they would spend yearly, and that's 14% of their total healthcare budget. Before I go on to the next slide though, I want you guys to just take a guess. I'm going to give you a hint that I'm tricking you basically in this actual diagram here into what country you probably think has the highest prevalence of obesity right now. I'm not able to see the chat box, but I'll take a look at it a little bit after. So this graph here shows us the obesity rates according to population. So United States is definitely at the top, is number 2. But counterintuitively, a country like Kuwait is actually at the top, which would fall into more the middle income type area. And that can speak to that trend that I just spoke about. Okay, so let's move on to actually assessing obesity and the different ways that we can do that. I'm sure many of us would be aware of the BMI, which is body mass index, and it's a simple ratio of weight to height. And this is how it's calculated, divided the weight in kilograms over your height in meters squared. I'm going to talk a little bit more about that later. But BMI does have its limitations in terms of the clinical applications. So in some cases, we might need to refer to other areas of measuring obesity, such as body fat percentage and waist circumference. So waist circumference is one that's actually very important in terms of physicians assessing patients' cardiovascular risk, which is what we're really interested in terms of obesity management. So persons might not necessarily be obese based on their BMI, but they might have a larger waist circumference. And that tells us that they may have increased amounts of what we call visceral fat, which is the fat that surrounds the organs and tends to further increase your cardiovascular risk. Waist to hip ratio is another way that we can also look at abdominal obesity. Skin fold testing is another measure of body fat percentage. And there's also imaging that can help. Obviously, we don't really use that much here in Barbados, but I guess in those persons, in those countries with a lot higher income, they will be able to assess it using CT or MRI scans as well as DEXA. So this will be particularly more advantageous in research settings where you need a lot more accurate assessment of obesity. So let's talk a little bit more about BMI. So as I said before, it's used to evaluate obesity and overweight based on height and weight. And the relationship between BMI is closely correlated with body fat percentage. And that's why it's used to really assess obesity. And they are classified into different areas. We have underweight, which is less than 18.5. Normal weight is 18.5 to 24.9. Overweight would be 25 to 29, obese, severely obese, and morbidly obese. So this is just a diagram here illustrating that once again. You can see moving down the screen here. So you guys can, I'm not sure if you guys know your BMI, but you can kind of try to calculate it and put yourself in whatever category you think that you would fall into here. And that would give you a bit of information in terms of where you stand. But as I said earlier, there are some caveats in relation to BMI. Its limitations can really occur with persons who are very muscular. So the reason for that is that obviously muscle is a lot more dense than fat is. So persons who are very muscular, they might have a heavier weight, but their actual body fat percentage is nowhere near that of an obese person. So these two persons here can possibly have the same BMI, but their body fat percentages are vastly different. So there's some limitations, and obviously as clinicians or even as yourself assessing your personal self, you have to be aware of these caveats. BMI also in older persons is something that we also have to look at closely. So muscle, again, gradually declines with age, and it comes into play here in terms of what happens with BMI in older persons. So normal BMI in an elderly person might actually be concealing a truly high body fat percentage, because looking at this little graph that I have here, a younger person has a lot higher body mass, muscle mass, versus a 75-year-old, which has a lot higher body fat percentage and less mass. So they might have normal weight, but they do have a higher body fat percentage. So assessing their body fat would be more advantageous in the older population. And that comes into play again here in terms of how BMI affects mortality in older persons, with the lower risk actually being in the what we call the overweight range here, 27 to 27.9. And even up to 30, which would be considered obese, would be good for an older person. So what are the health consequences of obesity? Obviously, as we know, it's associated with a higher risk of death and morbidity. And that's because of its close interlink with other non-communicable diseases, such as diabetes, hypertension, as well as cardiovascular diseases. The life expectancy of both men and women of high BMI, which is over 45, which should be classified as morbidly obese, around 20 to 30, is 13 to 8 years lower than those with the respective both gender as well as age with normal BMI. So that's a whole up to 13 years that you're cutting off of your life just by being obese. And those of us who have any knowledge in terms of statistics, this would be adjusting for other things as well in terms of like other comorbidities, their lifestyle as well. Right. I thought this was a very interesting statistic in terms of the deaths that can be attributed or closely related to obesity in in first world countries. In the UK, 7% are attributed to obesity, but in America, up to 20% can be attributed to obesity. And as I would have said earlier, there are wider implications, not only the individual level, but we also have to look at society as well in terms of economy, national productivity. For example, an obese person might have certain health consequences. They might need longer sick leave, and that can also affect national defense, particularly in the US, an issue that's been coming up because they have such a high prevalence of obesity. Their army reserves are persons who are joining the army are that pool is dwindling very fastly. So this just looks here at other health consequences. And as we can see, there are many, many ways that obesity can affect a person in terms of the heart, cardiovascular disease, immune system, mental health, cardiovascular system, the endocrine system that deals with hormonal and sexual and reproductive health, which we're going to get a little more into here. So in talking to Monique, we actually spoke about making sure that when we're having this discussion that we're not going to be using any connotations towards persons who may be overweight or obese that would be negative. And that actually brings up an interesting point, some developing research in terms of obesity stigma and its implications towards obesity management and the perpetuation. So some definitions regarding this first would be weight bias. And that refers to the negative attitudes and beliefs about others solely based on their weight. And these negative attitudes may be manifested in stereotypes, and prejudice towards these persons. And the thing is that obese persons obviously, they sometimes would internalize this weight bias, and that would affect their self-esteem. Many of us, we live in the Caribbean, and I don't know how many of you guys, but I find that you're getting fat or you're gaining weight or you're losing weight is a greeting before somebody hasn't seen you in a long time. That's the first thing they're going to say rather than, hello, how are you? How's your life going? And I find that very, very interesting. Obesity stigma now is similar to weight bias, but it involves actions that are against obese persons, and that would lead to exclusion and marginalization of this particular group. And that can be in workplace, healthcare settings, as well as educational settings. And weight-based discrimination is another form of that where it's acted upon. So just want us to, as we go away from here, to make sure that we are not perpetuating this obesity stigma when we're going out into the world. And the next time you see somebody that you haven't seen in a while and they may have gained some weight, just start the conversation by saying hello. Simple as that. So let's move on to the second part in terms of defining sexual and reproductive health. So this was taken from the World Health Organization, and this is specifically to sexual health, and it's defined as a state of physical, emotional, mental, and social well-being in relation to sexuality. And they made a point here to ensure that we understand it's not merely the absence of disease or dysfunction, but really speaking to wellness. And from this definition here, we can even see that there are many different dimensions of sexual function that can potentially be affected by obesity in sexual function. So I'm not sure if many of us to be aware of, I actually think I need to say that back. I'm sure many of us, are aware of the sexual response cycle, but I just wanted to review that. So the first phase would be the excitement phase. So that's basically the foreplay phase. That's the first stage of the human sexual response cycle. That's when persons may be kissing or are touching, and the excitement is really building. After that, we enter the plateau phase, and that's when we may actually be engaging in the physical act of sex, and the excitement tends to build up. And during that phase, I want us to pay close attention here in terms of there's increased circulation, increased heart rate with both persons involved, increased sexual pleasure and stimulation, and further muscle tension. So even looking at that particular phase in terms of the plateau phase, we can see, for example, heart rate and respiration will also increase circulation. Persons involved there would really need to have a healthy cardiovascular system, and obese persons that can potentially affect that particular phase. We come now to the orgasm phase, where persons reach the summit basically of the encounter and actually have an orgasm. And then the resolution phase occurs after orgasm and allows the muscles and so on to relax. Blood pressure drops, the body slows down from its excited state. Again, we can see here reflections of the importance of good cardiovascular health in terms of the gradual control of the blood pressure. So persons with obesity, both in the resolution phase and the plateau phase, that there may be an issue there if their cardiovascular system is affected by their obese state. So I wanted to again just reiterate that in terms of the physiology of sexual response cycle. And I'm just going to highlight here, I know it looks very complicated and many different medical terms, but these abbreviations here stands for heart rate. HR is heart rate, BP is blood pressure, RR is respiratory rate. And also in this area here, perivaginal arterial dilation, obviously that has to deal with the arteries. So again, we can see that good cardiovascular health is paramount to the sexual response cycle. And if it is complicated in any way, it could impact your sexual function. So let's talk about sexual function in women a little bit, because it's a little bit more complex. Because sexual function in women is more complex versus men. So sexual function in men may involve, in women may involve either increase or decrease sexual responsiveness, and it can be the classification is determined by the symptoms, and there are 5 major categories of decreased responsiveness and just 1 category of increased responsiveness. So we have disorders of sexual desire or interest, and that may be characterized by an absence or decrease in sexual interest, desire, or sexual thoughts. And that can be as a result of some mental situation you might be going through, anxiety, depression. Can an important symptom of both of those is actually decrease in sexual desire. Sexual arousal disorder is just a lack of genital arousal. Orgasmic disorder involves the absence of an orgasm, and it can either be markedly diminished intensity or delayed in response, despite actually having high levels of arousal. Vaginismus is another one that's just reflective tightening of the vagina, and that can come after also psychological implications like sexual abuse. That can be a physiological response to that. Dyspareunia here is just a medical term in terms of pain during sex. And pain during sex, we normally define that either as deep, meaning that you might have pain maybe in your lower abdominal area. And you also can classify it as superficial, where it is actually in the vaginal canal. And that can be as a result of vaginal dryness or maybe like an STI. And the last one is just the one of increased responsiveness, which is persistent genital arousal disorder. So now let's put the two together. We spent some time discussing obesity and sexual function. Now let's make the connection here. So sexual dysfunction, this is just a definition in a wider scope, not just women, but again, similar though, sexual desire dysfunction, persistent arousal, which we just spoke about, orgasmic dysfunction, sexual aversion, sexual arousal disorder. Now, sexual dysfunction in men. So the one that really would come to mind, obviously, is erectile dysfunction. And that's defined as the inability to either attain, which is initiating that erection, or maintaining penile erection sufficient enough for sexual activity. Early ejaculation is another aspect, and that occurs in men, and that's ejaculation either before or shortly after sexual stimulation. Delayed ejaculation in men is an undesirable delay in attaining an orgasm, and anejaculation, which is just a complete absence of ejaculation after sexual stimulation. So this diagram here, I want to draw your attention to, again, it's very medical, but what I want you to really focus on are these little blue areas here. So these are basically the vasculature, like the arteries and the veins that are involved in the actual process of having an erection. And men, much like other arteries in the body, they can be affected by plaque buildup. And if these are once again under any complication as a result of obesity, we can see how that can easily result in erectile dysfunction. Okay, right. So in terms of actual making the connection between obesity and sexual health, the research itself, there isn't much, to be honest. And even beyond that, for women, there's even less actual research. However, there have been some studies that have shown a strong link between obesity and sexual dysfunction. Sorry, that's supposed to be particularly in men. Some studies indicate a statistically significant negative correlation between sexual quality of life and BMI. So that basically means as your BMI increases, your sexual quality of life will decrease. Great. So let's speak a little bit more about erectile dysfunction, given that's where the majority of the evidence is. So a lot of these studies have shown that modifiable lifestyle factors like leanness have been shown to be very integral in maintaining good erectile function. And men with higher BMIs, particularly those which are, for example, 28.7, tend to have a 30% higher risk of erectile dysfunction compared to men with normal BMIs. And that's quite a significant risk for those with just a marginally increased BMI. Because if you can remember, the cutoff for within the overweight range is 25. So that's not even within the obese range, that we can see quite a significant amount of higher risk of erectile dysfunction. And in general, men with erectile dysfunction tend to be heavier and have a greater waist measurement. So again, going back to that first, how we were classifying obesity, waist circumference is a very important aspect of it because it tends to link with increased risk of things like cardiovascular disease, hypertension, and high cholesterol, which is what this word here means. So what really causes the link between obesity and erectile dysfunction? Some postulated causes were things like insulin resistance. So insulin is a hormone that's mainly used in the regulation of blood sugar. So its function is to really move the sugars from whatever you eat from the bloodstream to do whatever task. So it can take it to the muscle if you don't have to do any exercising, or it can also take it to the liver to be stored, or to be stored as fat. So with insulin resistance, what happens is that the insulin isn't working as well as it should. So you need a lot more insulin to actually get those tasks done. And that can actually perpetuate other complications. Dysfunction of the vascular lining. So a big aspect of obesity research has been showing has been a connection, sorry, with inflammation, and increased inflammatory states within the body tend to have an implication in terms of the linings of the arteries and the veins that supply the different areas of our body, inclusive of either the penis or the vagina. So any dysfunction there as a result of any inflammation would tend to increase your risk of cardiovascular disease. Atherosclerosis as a result of obesity, again, can play a link. And as I said earlier, increased inflammation within the body. So this diagram here just again reiterates what I was saying in terms of things like complications associated with obesity, like diabetes, hypertension, high cholesterol, then lead to plaque buildup, causes thinning of the actual blood vessel itself, that decreases the blood flow to the penis and can lead to erectile dysfunction. So moving on again to another aspect of sexual dysfunction in men, which is the implication of hormones. So testosterone is a big hormone that is involved in sexual function in men. And I highlighted here under this diagram what its role. So it's important in sperm production, prostate growth, as well as erectile dysfunction. And it tends to be important in maintaining good sex drive as well as sexual performance. And men with very low testosterone levels tend to have increased incidence of obesity. And the reason for that is actually because the fat cells themselves actually metabolize or convert the testosterone into estrogen, and that can therefore lower your testosterone levels. So obviously a person who has a lot more fat mass have a lot more fat cells to do this actual process and can significantly lower their testosterone levels. And that has many different implications. So it can reduce your sex drive, lead to erectile dysfunction, reduce your sperm count, as well as result in infertility. So sexual dysfunction in women, again, as I said, the evidence really, there's not much evidence in terms of the linkage between sexual function and obesity and sexual function in women. Apologies for this typo here. But there have been some studies that have been able to show that obesity tends to affect female sexual function, including areas of arousal, lubrications, sexual satisfaction, and orgasm. However, it doesn't seem to affect their desire or their reports of having any pain during intercourse. The studies that have actually been done have been showing conflicting results. So some studies are showing that there's actually a correlation between high BMI and sexual problems, versus some other studies are showing that there's absolutely no link. So we really do need a lot more studies in this particular area to get us to help to really untangle this interaction. But additionally, the sexual response cycle in women is very, very complicated. It's not as clear cut in men that we can measure the presence or absence of an erection, but we have different things that really need to be assessed when we're assessing sexual function in women that makes it a little bit more complicated. Right. So I wanted to also touch a little bit on obesity and self-esteem and that implication in terms of sexual function. So first we start off by a definition, and sexual self-esteem is defined as a reflection of self-worth, and that encompasses a person's beliefs about themselves, and that can lead to their emotional responses based on those beliefs. And I was have said earlier in terms of things like weight bias and obesity stigma, they tend to be perpetuated, by the unrealistic standards of beauty. I'm not sure how many of us are on Instagram. When we go on there and we're scrolling, every other person or every other image is a person with a very, very tiny waist and bigger hips, and persons have abs 24/7 all day, all year. 365 days a year. And for the normal woman who has a job, who may have children, who has other obligations, that might not be realistic. But really, us having that information fed into our brains every day can really lower our self-esteem. And that can have other implications in terms of our sexual function. It can lead to things like depression and anxiety, which can obviously impact sexual function, but it might also reduce, for example, a woman or even a man, they might be less likely to cause sexual initiation, and therefore that can impact their sexual function and sexual quality of life in that way. So let's touch a little bit about diet, even excluding obesity. So there has been considerable research in terms of particularly the Mediterranean diet and its implications on erectile dysfunction as well as sexual function in women. And this Mediterranean diet has been shown to not only reduce the incidence of erectile dysfunction, but also men who already have erectile dysfunction. There was one study that showed that once they were on this Mediterranean diet, after 14 months, I think it was, there has been a significantly decreased incidence in erectile dysfunction. So it can help in reversing the actual sexual dysfunction. Testosterone. So again, men, as we said earlier, who are obese men, because of their increased fat cells, they tend to metabolize the testosterone into estrogen. So we have to make sure that they have a low fat diet as well as a low calorie diet. So in terms of testosterone levels, I really like find the Mediterranean diet to be showing any implications here. It was just generally a low fat diet, which is part of the Mediterranean diet, or low calorie, right? And lastly, higher consumption of processed meats and meat products tend to be associated with lower sperm count, the motility of the sperm itself, the volume of the ejaculate, and the percentage of normal sperm morphology, which are all areas that we normally assess in a semen analysis. In women now, as I said earlier, the Mediterranean diet also has its implications. There's this diet fad now of the ketogenic diet, which is basically a diet that's very low in carbohydrates and complex sugars, and it tends to force the body into an area of a state, of ketosis, and the ketones themselves tend to then further lead to diet appetite suppression, and it can help to assist with weight loss in that regard. And that particular diet has been shown to show some improvements with sexual function in women, particularly in the realm of arousal as well as lubrication. There have been some issues in terms of the sustainability of the ketogenic diet, because obviously removing an entire food group for the entirety of your life might not be sustainable. So there is some implication in terms of the sustainability. And the last thing here is an issue that I often would discuss with my clients on maybe a daily basis, which is the fact that diets which are very high in simple sugars and carbohydrates tend to increase your risk of yeast infections. And obviously that can have implications in terms of your sex life, and it can lead to superficial pain during intercourse, which is the pain within the actual vaginal canal itself. So I also wanted to touch a little bit on obesity and other reproductive disorders. I didn't want to.
Daisley?
Yes, please.
Just give you a time check. You have 10 minutes remaining.
I didn't hear that, sorry.
You have 10 minutes remaining. Just give you a time check.
Oh, sure. I'm almost at the end.
Okay, thanks.
Okay, no problem. Right. So polycystic ovarian syndrome, which is a reproductive disorder, is actually very common, characterized by menstrual irregularity and so on. And 80% of women with PCOS tend to be obese or overweight. And even with the groups that are lean, they tend to also have that increase in abdominal fat. So these are some slides that I took from a presentation I did on PCOS itself, and it shows the gradual movement here from insulin resistance, which is a big part of it, moving into fat cell formation and leading to obesity. But the real important aspect of it is this aspect, meaning that obesity feeds right back into the loop, and it tends to form a vicious cycle. So ladies with PCOS tend to have a lot of difficulty in terms of managing their weight, and they tend to gain weight very easily. This is just a slide here showing in terms of how this might manifest in terms of sugar cravings, and they might crave foods that are high glycemic index. Sorry, this is not supposed to be simplex, it's supposed to be simple carbs. And the last slide here is about obesity and reproductive cancers. So I just wanted to really make us aware that obesity tends to increase our risk of several different cancers, inclusive of breast cancer, ovarian cancer, cervical cancer, endometrial cancer, and prostate cancer. However, it tends to be in the reverse for our testicular cancer. So that's actually the last slide. I know that I talked for quite a bit, but thank you so much for your attention. And I will now open up the floor for any questions.
Dr. Daisley, that was a really, really good presentation. Thank you so much.
No problem.
I'm really glad that we had others join us. So just for those who may have missed my intro and so on, looking at obesity, NCDs, and sexual health, two separate public health issues and concerns, and the interlinkages between the two, and very little work being done. As you pointed out, very little research. It seems to be more research done on men. However, while what I notice, the higher rates of obesity are among women, but more research has been done among men. So, that's also perhaps maybe other public health students who are on or might be interested can look into maybe doing that kind of research for Barbados and the Caribbean. Are there any questions from our participants as yet? Not as yet? Okay. I was wondering maybe if we can look at maybe cases of NCDs and infertility. And I know it's such a big topic. And I said that we didn't have many medical students on, but perhaps, or persons with medical backgrounds, but perhaps you can speak a little bit then about pharmaceutical medications and linkages with either broader sexual health issues, maybe even to erectile dysfunction, maybe lowering interest in sexual desires, and maybe infertility. Maybe you can say a little bit about that.
Okay, sure. So again, even in terms of the research, in terms of how medications affect sexual health, most of the research is again in men, and a lot of the times is often the antihypertensive medications, which are medications used to treat blood pressure that tend to affect the male sexual function and cause erectile dysfunction. The reason for this is that, again, going back to that diagram that I would have shown in terms of the physiology of the erection, there are arteries and veins there that are very intricately involved in the erection. So those same arteries that the blood pressure medication are affecting to cause the blood pressure to be lowered are also in the penis itself. So they affect it in that regard and tend to increase the risks of erectile dysfunction. And often a lot of the clients really do not like that side effect. And that might actually impact their adherence to the medication. In women, there haven't been much signs of how antihypertensive medications or even diabetic medications tend to impact their sexual arousal or sexual function. But in terms of infertility itself and its link to non-communicable diseases, once again, very similar implications from the aspect of the cardiovascular health. A lot of these organs, not a lot of, all of these organs, sorry, are fed by arteries that are under the same implications of plaque buildup, endothelial dysfunction that can be as a result of high blood pressure or even diabetes. And that can lead to for example, in men, erectile dysfunction or decreased sperm count or decreased sperm quality. In women, PCOS is another one, as I said, that tends to be linked to obesity, but it also is very closely interlinked with diabetes as well. And that's a major cause of subfertility as well.
Great, thank you. Thank you for that response. So I wanted to contextualize it a little bit for the Caribbean, because I think obesity may have a different understanding, a different reading in the Caribbean than it does in northern countries, right? So we spoke about this, before I'm preparing for today's
Yes.
talk, and perhaps historicizing it a little bit. So maybe if you can maybe give some testimonies from some of your patients about their interpretation, understanding of what obesity is within the Caribbean context?
Sure. So especially during our actual discussion, within the Caribbean, and actually not only the Caribbean, but I find within the Black community and women particularly, obviously having a larger body size, particularly with the shape in terms of the bottom, is something that's sought after. So obesity is not really often seen as something that is actually bad, because men sometimes, if women come in and they have some complications related to obesity and we have to help them to lose weight, their partners are often sometimes upset with that weight loss because they're saying they don't have anything to hold on to or grab onto. And that is not what's really happening in other realms of the world. For example, particularly in the white community, is not often seen as something desirous to have to be a lot of larger scale. So those persons tend to be actively more trying to maintain a lower BMI. Sometimes they would go further to the other scale and have like increased incidence of like anorexia and bulimia. So really, as you said, is the cultural context is important in obesity management.
Yes, thanks a lot for that, Dr. Daisley. And I came across an article in the Jamaica Gleaner, it's 2016, which featured our VC Beckles, and who kind of took to historicizing the diabetes and hypertension rates in the Caribbean, and looking at the diets of the enslaved, right? That
Yes,
were basically forced to consume what was on the plantation at the time.
yes.
So the high sugars, the salted meats, so the salt pork and
Mhm.
salt fish and so on. So seeing this, our rates of diabetes and hypertension the way they are now is part of this colonial retention. Would you say that you also see something like that in terms of I'm thinking maybe in terms of behavior change strategies and the whole movement towards healthy living, healthy eating, healthy lifestyles? What would you say with regards to health promotion? How do we go about behavior change? Changing these behaviors are part of our ancestral DNA, of our behaviors coming out of a colonial society.
Sure. So discussing the etiology of obesity, often we talk about genetics and being passed down from one generation to the next, but eating habits, as you're implying, are also passed down. So even within this generation, oftentimes clients would come in and they would talk about they want to try to make these changes, but if they're living in a household, for example, with their grandmother and their mother, who are still making these same meals with lots of sugar in it, lots of high fat as well, it makes it a lot easier, so a lot harder, sorry, to initiate this health change as well as maintain it. Yesterday, we actually met with the Childhood Obesity Prevention Coalition, and I actually raised a point similar to what you're saying here, because it's so difficult for us to tend to get away from these different meals, because the meals are not only something that we just eat, but it's part of our culture basically. So we really have to focus on reinventing some of these meals to be made in a healthier context. That's my opinion, because I think moving from just having these high carb diets straight, like going from black to white, might be a more difficult jump versus if we try to make the change more gradual in terms of making certain meals a little bit more healthier, but might be palatable, and then maybe a few months later, then moving into that like even stricter diet would be an easier transition and would be more sustainable.
Yes, great. Thanks for that. I agree totally. So WHO, World Health Organizations, in looking at NCDs, and for them, they took a very comprehensive life course view of
Yes.
approaching NCDs. So from preconception to
Yes.
pregnancy through to childhood, adolescence, adult, then into the older adult. based on your experience of working in this field of obesity, what would be your call to action? This is my last question. Your call to action then for Barbadian population, maybe hopefully broadening to the broader Caribbean society, but maybe starting here in Barbados, based on your experience, your call to action.
Okay. So even in terms of what you're discussing there, the etiology of obesity itself is not clear cut. It's not point A to point B. It's very, very, very complex. Even beyond the life course aspect, within the actual individual themselves, there's so many different factors that come into play that can increase their risk of developing obesity. And to really assist our population, are giving them a fighting chance of actually being able to win in this battle, we really need to employ systems. So we have to really look at the individual aspects. Maternal health is a big aspect of it as well. Childhood obesity that we're really fighting towards now. Education, addressing socio-economic status within the population, the greater foodscape, for example, the easy access to fast foods versus the financial deterrence to healthier foods. There's so many different aspects that we really need to really address. So I think the starting point is actually more so at a policy level than at the individual level. I know some persons there it can be a controversial topic, but I do think that we really need to start at a policy level in terms of changing our entire landscape. For example, one making increasing the ease for persons to be able to walk. Right now might not be the time, but also looking at our economy, also to really help our persons to have a fighting chance. So I think the starting point is to really see obesity management and prevention at a systems level, to have a broader look versus actually just starting at the individual level, because it would be harder to have a large scale change if we're focusing at the individual level rather than at the health policy or even at the healthcare aspect.
Okay, great. Thank you. And that's a great answer. And again, I was looking at, yeah, so there's obesity and the linkages with NCDs, but then looking at NCDs too, I find that we don't focus or talk a lot about the genetics in terms of, yes, so we focus on maternal health and preconception and pregnancy, but then we don't have a conversation around the father's health and how some
Agreed.
of these diseases can be, genetically transferred
Yeah.
to the unborn. So I think perhaps that is another opportunity then for looking at how to tackling also from the policy level, right? So how do we approach men's health, and how do we approach women's health, and how do we combine them, approach them together, maybe as families, as communities, as part of the
Exactly.
wider society. Yeah.
Agreed.
So I want to thank you so much. Are there any questions? I'm not seeing any questions from the floor. So I'll take this opportunity, Dr. Daisley, to thank you for really engaging our presentation. I thoroughly enjoyed it and I learned so much. And I want to thank also our participants who joined us today. And Kelia, as always, for providing technical support. And just to say, next week we will be focusing on breast health awareness with a focus on self-examinations. So once again, thank you, and please complete the evaluation form that Kelia will be sending to you. You can also identify topics that you might be interested in us to facilitate maybe next semester or so. Okay, everyone, thanks again, and enjoy the rest of your afternoon. Take care.
Thank you. Bye.
Bye-bye.